It is a huge honor to be interviewing Dr. Michael Scherer today, and I think it's ironic that your last name is Scherer as you're sharing information. I don't pay any of my guests for money. I don't get paid any money from any of my guests. I'm not here to promote a product or anything. I just like to I love doing podcasts. It's my absolute newest, hottest hobby. I'm coming up on a year and 150 of these things. I just like going to lunch with a guy like you. By the way, you're Michael Scherer. You're a share of information, but you said Scherer actually originates from a barber surgeon, so you were named correctly at birth?
Yeah, this is true. You know, certainly my father was a medical surgeon. My grandfather was a medical surgeon before that. And I'm the black sheep that went into dentistry. But, you know, the funny thing is that they're all laughing now. But dentists, I mean, we have a wonderful career. The outlook and potential of dentistry, not only with implant dentistry, but with all of dentistry in general, it's amazing. This is the best profession. I wouldn't change it for the world.
And what's kind of ironic about what you just said is the curse of dentistry, because in dentistry, we're all surgeons. We all work with our hands in surgery, whereas the physicians, if they don't really have the eye-hand coordination and they don't want to do heart surgery, brain surgery, whatever, they can go be a family physician who pretty much just reads scripts and talks to people and writes prescriptions and blood work, and we're all surgeons.
No, that is the absolute truth, and that's also somewhat intimidating too, because certainly if one of us goes down and we're out in bike riding accident, or we decide to go snowmobiling and you take a header, you take a fall, as a dentist, you don't necessarily have the ability to say, oh, no big deal, I can be in a cast for a couple weeks. No, it's a big deal. So, you know, I mean, one of my staff members right now is out because she fell off a horse, and it's been, 2.5 months, and we're holding the spot for her because she's such a dynamo. But, as a dentist, I have to make second choices about doing crazy stuff because I got to feed all of them and keep them working and employed. And it's a heavy weight, but I take it very seriously.
And you're a prosthodontist, and you're a very serious prosthodontist. You're an assistant clinical professor at Loma Linda. You're a clinical instructor at University of Nevada. You have a practice limited to prosthodontics and implant dentistry in Sonora, California. To our listeners, where is Sonora, California? Most of us in geography only learn that California has San Diego, LA, and San Fran. We haven't heard of the other 99,000 cities in California.
And that's true, and it's funny too because it's a sore subject here in Sonora because everybody thinks it's called Sonoma. You think that's where you're growing grapes and wine and everything, but we're the gold country here in the Sierra Nevada foothills. It's a small town about 2 hours east of San Francisco. And originally I came from Florida, and people asked me, how the heck did you end up in Sonora? And it was just kind of a strange series of events. My wife, she's also a dentist. She's an orthodontist, and she used to come up here to Yosemite and this the gold country as a kid. And when the practice became available, it was just the right time, the right place. And it's a more rural type environment and culture. There's only 5,000 people in my small town. But we draw approximately 65 to 75,000 people. And people then take it a step further. They say, well, you're a prosthodontist. What are you doing in this community? Well, in all fairness, there's quite a few retirees in my area, and it's just been beautiful. We've really had just tremendous luck with being able to connect with the community and to be able to offer the type of services that they're really asking for. So it's really a lot of fun.
So was it founded by 49ers in 1849?
It was actually. Gold was was found not too far away from here, a few miles north of here. But actually, the largest gold nugget ever to come out of California is about 5 minutes away from my office. So, on my backyard, whenever I go for a walk in the backyard, you betcha I'm looking around. That's for sure. But Sonora was actually named after the initial gold rush people of the part of Mexico, Sonora, the Sonoran Desert. Those are the people that first settled in this area, and they named the town after that. Mm-hmm.
So you're so this is something that we don't talk about in dentistry, but at 64 years of age, 10% of Americans are edentulous. They have no teeth. At 74 years of age in America, it's significantly higher. What is the state of edentulism? Is it growing? Is it shrinking? Is edentulism here to stay for another 100 years?
That's a fantastic question because a lot of us in dentistry and our focus in the clinical as well as the academic side, which can be somewhat frustrating for a lot of clinicians that really do removable dentistry quite a bit, is the sentiment that edentulism is going away. And yes, the rate is declining. There is a constant shift over the past 30 years or so of the declining rate of edentulism. But, in this country, we have this really magic statistic. It's the baby boom population shift. And over the next 15 years approximately, we're actually going to have an increase, a net increase of the number of edentulous arches as we move forward. So the rate is decreasing. However, the total number of edentulous patients and edentulous arches is actually increasing. So, the focus on full arch implant dentistry is significant. And, certainly that depends upon your area. Maybe if you're practicing in a place that's in a much younger population, you might not see it as much. But I tell you, I mentioned before, we're not far from San Francisco in the Bay Area. And the Bay Area is one of the highest socioeconomic areas in terms of income and living costs in the whole country. And when I meet clinicians, even from those areas, they say, no, I'm really seeing an uptick in the number of edentulous arches that I'm treating. So it really is very diverse. And what happens is that, yes, we tend to focus in on veneer cases and the cosmetic dentistry. But yes, as you mentioned before, we're all surgeons. We're all medical surgeons. We're all cosmetic dentists. No matter what type of dentistry you do, oral surgery, endo, we all treat aesthetics. And when it comes down to it, the full arch implant dentistry and removable is a true aesthetic rehabilitation. Every time we work on our patients for complete dentures or with full arch implant dentistry, we are doing full arch reconstruction. And, across the board, it's just frustrating because people have the philosophy that I should, just kind of ignore it. I'm going to go take courses that focus on bonding number 8 and 9 or putting an implant at number 8 and 9. And to tell you the truth, if I focused 90% of my practice, which is what some of the experts in implant dentistry and aesthetic leaders claim that they do, not only would I not have any patients to treat, I would be poor, and I would probably be so stressed because those cases are just so incredibly demanding. Give me a denture any day.
Exactly. Good and well said. I want you to address the first, my first question to you is something I've seen since I got out of school in 87 to now in these 28 years is that on Dental Town, where we have 202,000 registered dentists from 206 countries, we had to separate we had to separate the on CAD-CAM CEREC from E4D because anytime some poor E4D guy would make a post, somebody from CEREC would have to go on there and say, oh, you got the wrong system. It's like, buddy, he's past that. He's got an E4D. Can we just talk about the E4D without always having to have a CEREC nut job in there, saying, oh, you made the wrong decision. And we also had to separate the dental implants from mini dental implants because anytime someone posted a mini dental implant case, all these people would go in there and say that, minis aren't justified. It should have been full root form implants, et cetera, et cetera. Yet there are some oral surgeons who say that, that if someone walks in your office with a denture and all you can treatment plan is a Mercedes-Benz, 6 implants on the lower, 6 on the upper, 2 12-unit bridges for $50,000, that probably 90% of Americans couldn't afford a $50,000 denture to a full fix, and that maybe there should be a lower-cost Chevy with mini implants or a couple with overdentures, and you seem to be the master of that. So I want you to address that question. Why did minis have to be separated from implants in our profession?
Well, Howard, thank you. Those are excellent questions. And first of all, let me just emphasize to you my congratulations for building an incredible network. The Dental Town Network is full of some of the most interesting people that are so passionate about what they do. The ability for using that website to connect with people all around the country and the world is remarkable. And I really congratulate you on that for being able to be a part of the bringing together of the community. And you bring up a very interesting point in terms of this discussion. I can't tell you how many times where we start interacting with other clinicians, doesn't matter if you're a general dentist, oral surgeon, whatever your training is that we all interject a lot of our own personal philosophies and opinions when it comes to how I would treat a situation. And many times I get emails every day, almost 5-10 emails a day about helping treatment plan cases for overdentures. And it's, I get a panoramic that just says, what would you do here? And I say, I don't know. Introduce me to the patient. The number one rule of treatment planning is know your patient. There's this fantastic quote in Implant Dentistry and Prosthodontics that says the first thing that you should do is meet the mind of the patient, not the mouth of the patient. And whatever sort of dentistry you do, the best modulator and best predictor of success is how well you involve your patient as well as communicate with your patient. So it's true when it comes to full arch implant dentistry or any sort of restorative treatment plan, I love doing dentures, overdentures, narrow diameter overdentures, full arch fixed, full arch metal ceramic restorations. I look at a patient straight in the face and say, my opinion is just to treat whatever you think is the best for you. I will show them every single option. Now, I don't cloud them and just throw too much at them. I show them the model of this and this and this, but it first starts with communicating. And many times when you start talking to a patient and say they have lost all their teeth, no problem. You have a few different choices. Maybe they have existing complete dentures. What's the reason? What's the reason they're coming to see you? I'm doing pretty good with my teeth, but when I'm out and about with my friends, I'm at the movie theater, I'm at dinner, I just don't have the confidence to be able to do this or that, and sometimes I just leave my lower at home. Okay, they might be talking about stability. Just adding a couple of implants, whether it's 2 standard diameter implants or 4 narrow diameter implants, perfectly fine. I've done so much of that treatment with so much success, either standard or narrow. It just doesn't matter to me. But I have the opportunity to not only use a standard versus narrow diameter implant in my practice from a few different directions. But then also I'll ask a patient, I'll say, how do you feel about your teeth coming in and coming out at night or during the day? Is that something that bothers you? And many times if they're an existing denture patient, it's, I'm doing okay, no big deal, I'll live with what I got. But if they're a transitional patient, somebody who's about ready to lose all their teeth, many times they'll say, ooh, I don't know if I really want to have my teeth come in and come out. They would probably be steered more towards the fixed option, but I'll still tell them about the overdenture option. Because let's be frank about this. Yes, I understand we're providing a service that we don't always focus strictly on money, but we're talking big bucks for our patients. Many times the difference between $2,500 to $5,000 is a moderate investment, but to make the jump from $5,000 to $7,000 to $25,000 to $30,000 an arch is extreme. And if you look at the literature that's associated with overdentures versus dentures, the literature is clear. The 2-implant overdenture option, even when price is a consideration, has such a huge benefit on quality of life versus a standard complete denture. And it's approximately 4 times more expensive to go for 2-implant overdenture total cost versus the standard complete denture. Then, when you look at the literature associated with 2-implant overdenture or 4-implant narrow diameter overdenture versus a full arch fixed restoration, yes, the cost takes another 4 times leap for total cost. But the literature is not clear about the quality of life improvement of full arch fixed versus full arch implant retained restorations. It's very difficult in the academic world. As you know, I live part of my life in practice, part of my life in academics. It's very difficult to convince academicians and universities to do research that's incredibly difficult and expensive for obvious reasons. So there's this wonderful series of articles from the Jocelyn Fine Group at McGill University in Canada looking at a crossover study of overdenture patients versus full arch fixed patients. They started one group with an overdenture and another group with fixed. And at 6 months, they switched them over. At the end of 6 months, the fixed became the overdenture and the overdenture became the fixed. And at the end of the next 6 months, they got to choose which of those 2 prostheses they would want to live with for the rest of their lives. It's about a 50-50 split. Who chose the overdenture versus the fixed? And that's really amazing because a lot of us in implant dentistry, and especially those on Dentaltown, forget Dentaltown, anywhere people have the mentality that we interject our own philosophy on our patient. Because I know you and I, Howard, we would look at this and we say, I probably don't want to live with a denture. You and I would probably say, no problem, I just want fixed, that's what I want to do. But we're also dentists. We say, you know what, I just don't care how much money it costs because I see the challenges coming in with overdentures. We have to empathize with our patients because, yes, we have to focus on giving them the best return and the best options, but sometimes full arch fix is not the best for that patient because they might not have $25,000 to spend. So yeah, we can put in 2 implants in the anterior mandible or the anterior maxilla and convert them later to a full arch fixed if we place the implants in the proper position. Or if we're considering narrow diameter implants, quote unquote minis, I can tell you I've had such a good return on my investment with narrow diameter implants, especially the ones that I use from Zest Anchors. They're amazing. Long story short, those implants in the anterior mandible, I have not lost a single implant. And I've placed a lot of those implants and I immediately load them all day. It's incredible the results that I get. So if I have a narrow ridge, I automatically go narrow diameter implant for overdentures. It's just a piece of cake because I know my patients don't want to necessarily go through all the grafting and all the other surgery to do it. I got to tell you, I don't understand the quote-unquote mini hate. A lot of it is left over from earlier designs, and part of it is, as I mentioned before, just our own philosophy interjecting. And we have to look past that because there's wonderful options out there.
We talked to an oral surgeon in Germany who told us 25 years ago he placed 1,000 implants a year and they were all root form. And now, 25 years later, it's 500 minis, 500 fulls. I mean, he's now half and half, so is mini implant not really the right term? I noticed you use narrow diameter, and when you said mini, you put it in quotations. Is narrow diameter implant a better term? Anything under 2.8 millimeter diameter is what you're talking about, or?
So there's some debate there when it comes to the verbiage. There's this wonderful article from a researcher named Bidra that went through and actually defined the definition between mini and narrow diameter, and there's some crossover. So if you look at the standard design like the MTech or the Shatkin style dental implant, those are minis. They are true mini implants because they're a single piece implant that's meant for a variety of indications, including fixed versus removable, but typically if you want to use them for overdentures, that's kind of what the original design for. The implant that I use is the Locator Overdenture implant. It's a 2-piece implant that's a narrow diameter implant. And the reason is strictly when it comes to this, it's marketing, in my opinion, because I can't tell you how many patients that I've had come into my office or at the universities that look at me straight in the face, Howard, and they say, you're not going to put one of those minis in me, are you? I mean it. There is some philosophy out there from patients, and they say, the term mini makes it feel like you're doing less of a service for me. A lot of the marketing has been, you just drill a tiny little hole and you screw it in. It's like placing a post and core. No big deal. Anybody can do it. No, this is implant surgery, doctors. You have to treat this real. And part of what I do in our training courses, like at UNLV and some of the variety of different training courses where we teach how to do these implants, you have to treat it like it's a regular implant. And that's where doctors have more success. And part of what I've done in my practice is say, I have a standard diameter implant for those normal ridge situations, and I have a narrow diameter implant for the narrow ridge situations. And patients look at me and they go, oh, that makes a lot of sense.
So you're going to be listened to on this in 206 countries. And in some countries like South Korea and Germany, 3 out of 4 dentists place an implant in the last 30 days. And in America, 95% of general dentists have never placed one. Why is that? And to the Americans listening to you, why is that? And how can they start? How do I get from I'm on the first floor, I've never placed one, I got to get to the second floor? What would be the first step? What do they need to do?
So the first step, to give you a plug, is to get on Dental Town. And I mean it. Get on there, join the community, interact with the dentists out there. There's such great people on there, especially on the implant forum, that are willing to help. Really willing to help. And part of it is that you just got to get past the initial holy crow mentality, the fear. You have to take some sort of educational initiative to really jump in.
But why,
And
why do the Americans have more fear? I mean, why do you think specifically American dentists versus Germany and South Koreans that dove in head first?
it could be related to the litigation system. It's hard to say. I mean, we're in a constant era of fear, and you got to just go to one of these courses. No, fear about it. When you go to a course like that's given by one of the insurance companies, malpractice attorneys, and they really hammer to you about all the medical legal lawsuits about implant dentistry, and it's true. You do have to be very careful. But the number one step that you should do is not just to jump into it haphazardly. Get in there, get educated, get comfortable, and have a mentor. Have somebody that you can partner with, either a training course, go through a university, something that's well developed, maybe through an implant company. There's a whole host of different implant companies that either have mentor-mentee relationships, whether it's through Dental Town, mentor-mentee, or you seek an individual provider or practitioner. Heck, you go down to your other dentist down the street who's doing a lot of implants and you start hanging out at their office. It's the simple philosophy of see one, do one, teach one. And that's something that we learn in residency, either in a specialty training or in a GPR program, where you just got to see it a bunch of times. And then you get to do one with the help of that mentor. And then when you do enough of them, you get to go and you become the mentor yourself. And the educational triad, the see one, do one, teach one, is so critical to my philosophy that I love teaching because of that. Not only do you interact with the most amazing dentists around the country, in fact, I see pictures of people that come to my courses. There's one, I won't name her name. I just got off the phone with her a little bit earlier. She's on the cover of the Patterson catalog. It's incredible. She took one of our implant courses at UNLV, and now she's placing implants. Sometimes all it takes is getting in there, having a couple of mentors, taking a formal course, putting in a few implants, whether you do it here domestically or abroad. Just get in there and just do a few to get that internal gut feeling removed from the system.
So your courses at Loma Linda and Las Vegas, your course where you teach dentists how to place implants?
So what I do at Loma Linda is I'm a professor in the prosthodontics department where I teach only the residents working with dental implants and also with surgery. At UNLV in Las Vegas, we do surgery courses for general clinicians to come in to learn how to place implants, either standard or narrow diameter implants.
And how do they get information about learning from you in Las Vegas?
So you can go to the UNLV CE website, just type in Google UNLV Dental CE, and it'll come up. There's a whole schedule that's on there.
Fantastic. So if someone has never placed an implant, you're primarily placing Zest anchors, two-piece implants, as opposed to a single MTech Shackins single-piece mini implant. You're using a Zest narrow diameter implant, and it's in two pieces.
It is. I use standard and narrow diameter implants in my practice. I also have a wonderful oral surgeon in my community that I collaborate with, especially for more of the complex cases, for all on 4 full arch fixed, and as well as routine cases. I believe in collaborating and then also doing some yourself. I place a lot of the Zest Locator overdenture implants, plus I also do place the Biomet 3i system because I absolutely love something called the Encode. Encode is just incredible. It's basically a healing abutment that has a couple of notches on the top that allow me to do a digital scan. And the healing abutment stays in the mouth after the implant's been placed. Then after integration time period of approximately 8 weeks, patient comes in. I don't do anything other than use my digital intraoral scanner. And then next time the patient comes in, I remove the abutment and the crown goes on. It's magic.
Wow. So how do you want to start this discussion? Somebody's driving to work right now. And my average listener, podcasts are about multitasking. Mm-hmm. Most of them are doing it on their hour commute to work, rural or urban, it doesn't matter. And then a smaller percentage are doing it on the treadmill or while they're washing dishes and doing laundry and all that stuff. So I've never placed an implant, and I got this lady, and the best one would probably be, your grandma or a relative or cousin or uncle. How would talk about treatment planning this? Would you just 2, 4 They've heard of hater bars, dolder bars. They've heard all this stuff. Talk them through your prosthodontic journey. How should they look at this denture? What would be a good entry-level start? Should they be doing two, overdenture, dolder bar, hater bar? Go, just take it away.
Sure. What is really the most bang for my investment time, both monetarily as well as emotionally in my own practice, are first molars and upper bicuspids. Without a doubt, the implants that we do the most work with are 3, 14, 19, and 30, as well as upper first or second bicuspids. If I were to pick any implant for a clinician to place their first implant, it would probably be one of the upper 3 teeth, meaning first molar, second premolar, or first premolar. Those absolutely the best implants to start. Somebody with a high sinus, it's already been extracted, you have a nice ridge waiting for you. Your first immediate placement implant should be a maxillary bicuspid, without a doubt. Where clinicians kind of get into a tricky situation is when they want to do tooth number 8 and number 9 as their first one, or somebody that's just very particular. You think, oh, second lower premolar, perfect, circular root, amazing. But remember, you've got a little scary device sitting right next to that second premolar called your mental foramen. You want to be careful there. I 1000% of the time advocate for a cone beam CT. Without a doubt, in my own personal practice, it is my standard of care. Now, I'm not advocating the standard of care is cone beam CT for every practice, not in the least bit. But your first few cases should always be with a cone beam, whether it's a single implant, standard diameter, or for full arch implant overdenture cases. And a part of our training course at UNLV was working with clinicians and doing that. We split the group. Half of them placed single implants. The other half placed implant overdentures as their first patients. It's split. They both do fantastic. And we had to really, really pick our implants. They were always upper bis. There was a couple of lower single first molars. Always we had a cone beam, and we treated them just like our students at UNLV or at Loma Linda, where they have to come and do a comprehensive planning session, PowerPoint, CT scan, bone analysis. 90% of implant dentistry is the workup and the planning. Anybody can get in there and just go step 1 through 5, drill the little screw, and you put the thingy in the bone. Piece of cake. Sorry, oral surgeons, it's true. Okay, but the moral of the story is where people get into trouble is in treatment planning. Because we think of it like just routine everyday procedures where you go, all right, well, I've got a crown prep here and an amalgam here. Everything's good. All right, I'll fit in that implant. The patient broke it off. It'll be done. That's when mistakes happen. Now, if you're established, you've been doing implants for a long time, you don't need a CT scan. But your first few cases, it's all about taking that stress factor away. And guided surgery does that as well. And even though I'm not the hugest fan of guided surgery for every situation, it's a wonderful system just so that way you have something to lean on for that first case. And it gives you that little extra confidence to know that, I'm going to nail it. You've got something to fall back on, whether it's your mentor or your guide.
And are all CBCTs the same? Is there anyone you like more than others for the general dentist?
Everything's pretty much the same. It's really coming down to a price battle right now. I think still the standard, really one of the best CT scanners out there is the iCat. It's a wonderful system, but at $150,000 to $180,000, it can be kind of a heavy hit. I get this question a lot. I don't have a cone beam scanner in my office. I want to get into narrow diameter implants. I want to get into overdentures, but I'll just take a quick pano. If you go to a website, this wonderful website called conebeam.com, and you type in the little zip code of where you live, it'll give you the reference of all the places in your area where you can send your patient to, whether it's a scan center, which if you go to the Bay Area and San Francisco, there's several amazing scan centers there. One of them is Reveal Diagnostics. They're incredible. They work with a lot of clinicians. And then you look around your area, one wonderful resource for you to send a patient to is your orthodontist office. Almost every orthodontist that I know right now has a cone beam. I understand you might get nervous about sending to your oral surgeon or your periodontist to do a cone beam. They're like, oh, how come you're doing these implants here? No, avoid that. Send it to your orthodontist, get the case rolling, get some more information. Now,
Who's behind conebeam.com?
that I don't know. I don't know who runs that site. I just recommend it just because it's a wonderful resource for clinicians, especially that little map search tool.
That is amazing. So then on the cone beam, how do you learn how to back to the surgical guide? So you have a cone beam. You're going to do a surgical guide on Dental Town. There's all kinds of different threads about all kinds. Some of them, like the CAD cam Galileos, can take the image and help you mill out a surgical guide. There's other BioHorizons. Is it BioHorizons?
Mm-hmm.
What surgical guides do you like?
I use them all. The only one I don't really like is the CEREC one, just because, again, I'm probably going to get flamed on Dental Town about it, but I don't have a CEREC in my office. There is one sitting up in the closet upstairs. It's an older unit. I don't use it. Why? I just don't really want to. It's just too much work for me to do. It's too complicated. To tell you the truth, when it comes down to it, doesn't matter what your surgical guide system is, you just want it to have as simple as possible. The stuff that I've used literally every single guide system on the market. I really love the Anatomage guide, the In Vivo guide. That's a wonderful guidance system. Implant is a wonderful guidance system. There's a wonderful guide system out from the N-Sequence Laboratory in Reno, Nevada. Daniel Lopp has a wonderful approach to full arch fixed cases there. I've done quite a few of those cases. They're incredible. What it comes down to is you can also check out, I've got, just a quick plug, Howard, I've got a DVD series coming out on guided surgery that I've co-authored with Dr. Doug Chenin and Dr. Justin Moody, who Dr. Moody is, he's a big BioHorizons user as well. Dr. Chenin runs educational software as well as resources for doing cone beam imaging. I love cone beam. I love surgical guides. It has its limitations. I'm a big fan right now of using the In Vivo guide with a pilot hole only, because I want to be able to get that initial hole and then the rest is done freehand. And I do the same thing with my Zest Anchors, the surgical guide system for them. I help develop the guide surgery system for them as well.
And how many hours is your DVD? What's the name of it? What does it cover?
So the company is called Clinically Correct. Just go into Google and type in Clinically Correct Dental Company. And it's a three-disc series DVD that has a whole host of different information by myself, also Dr. Moody and Dr. Chenin, all about cone beam imaging, all about the information associated with it. It's a few $100s. You go buy the DVD series, they'll send it to you, and it's literally everything you've ever wanted to know about surgical guides.
Oh, so Clinically Correct. This is just for surgical guides.
They don't make the guides. It's just
no. I mean your DVDs.
Yes.
Okay, and
it's also cone beam analysis as well.
And do you have a www for that without a Google search?
Yeah. Let me get that for you. It's clinicallycorrect.com.
Clinically, I should have guessed that. And how many hours long is it in its entirety?
So. Let me just pull up the website here. It is a 4-disc series, excuse me. It's going in pre-sale right now, and it'll be available in September. So September of 2015, it's available. The retail price is $5.95. It is a 4-disc series. It covers everything from single implant to multiple implant guided surgery. And part of what
total hours? How many hours would those 4 discs be?
That I don't know. I could not give you that information. I know I contributed 2 hours myself. I think Dr. Moody did 2 hours, and Dr. Chenin did somewhere between 2 to 3 hours, somewhere in that range. So, just under 10 hours or so.
10 hours. And you know what would be great marketing is when we're done, have Dr. Moody email me, howard@dentaltown.com, and Dr. Chenin, and they'll also do a podcast. So we'll have 3 podcasts talking about this. That is amazing, because this is it's just a great way to get information and DVD and learning at home. All the research I'm showing is that humans love to learn in small segments, as opposed to just like going to a 10-hour course at one time. Yes. By hour 6 or 8, you're probably just fried or tired. Yeah, and so to be able to listen to an hour here, take a nap on Saturday, wake up, do another hour later that night.
And I
So
know, just let me interject 1 second there, because it's perfect. And I know I personally believe in that philosophy as well, because I do have 3 YouTube channels on the topic of implant overdentures. And it's interesting because I used to generate hour-long videos and very comprehensive, very detailed step-by-step for the surgery as well as the planning step. And I found that most of my YouTubers were tuning in approximately 14 to 16 minutes. And so the attention span is there, but you've got about 15 minutes to really nail it. So most of my videos that have been coming out lately are somewhere in that range, because I know we're busy clinicians. We don't want to spend the entire hour, but I still do the hour-long segment videos because there's people out there like myself that say, I'm getting into my first case. I want to know as much information as possible. But there's also people that are just like, click, click, click. I'm just going to do this quick video. And what's really cool is that I've had academicians, meaning academic people from all over the country and the world, email me and say, hey, is it okay if I show you your locator pickup technique video in my course at the school? I said, of course you can. That's my number one reason why I've done these videos, is so people out there can just try some different techniques.
I'm amazed at how many dentists. You just said YouTube channel. Most dentists don't know what you just said. They've never heard of a YouTube channel. Explain what a YouTube channel is.
Oh, it's fantastic. You just literally type in your web browser, youtube.com, and you go to the search box at the top, and you type in the most random idea that comes into your head. Say you want to learn about Zest Anchors implants. You type in Zest LearnLODI or Locator, and then you'll find all these different videos of how to do a 2-implant overdenture pickup in the mouth. Or if you want to learn a technique of how to place 2 implants in the mouth. Or if you want to learn how to do sizing for the tissue measurement for how high your locator should be. It's all in those videos. Say you wanted to learn about a zirconia dental implant. There's so many videos out there with surgery techniques on YouTube. It's really, really incredible. The social aspect of people going onto this site, YouTube, for free, posting a video for people just to watch their technique. And yeah, it's just incredible. The sharing economy that's going on right now, especially here in Northern California, is just amazing. And what you're doing with this podcast is amazing too. You're sharing. This is the sharing economy.
They said if you were born the same day Jesus of Nazareth was and listened to YouTube 24 hours a day for 2,000 years, you wouldn't have listened to all the YouTube channels.
That's a great statistic.
Isn't that amazing? But you and I are both educators, and we're trying to get them. A thing we have to remember, though, a lot of them don't want to learn unless they get credit for it, be it for their state or society or whatever. And what I've always thought about your amazing YouTube videos? You've already done the work. You should repackage them into an online CE course where we can tie them up in an hour where they can get AGD, ADA credit. You've already done the work. If you want to repackage into those, I would just kill to have some course series, because those online CE courses, they've passed 550,000 views, and I think a huge part of it is because they get credit for their continuing education, or they're trying to earn 500 hours for their FAGD, or another 600 hours for their MAGD, or at least not the hands-on part, 400 hours for the 200 participation. So if you ever have time, and I know you probably don't, but if you want to wrap any of those up into an online CE course, that would be great. I want you to address this. I know my job is to try to guess questions for people that are not talking to you right now. Is they've heard hater bars, dolder bars. Talk about where a ball and ring locator versus a dolder bar, hater bar. Are those passe? Talk about that.
I wouldn't call them passe, but if you went around in a room of clinicians in a large audience and you asked them how many of you are still doing bar overdentures, there's going to be a couple. But the number used to be much larger a long time ago. And the reason for that is that, number one, it's just much more complex. And number two, it's much more expensive. So if you have 2 implants in the anterior mandible, and if a bar and clip overdenture has been proven to be better over and over and over again, then the money's probably worth it. Maybe either to pass it along to your patients or just to eat some of that cost yourself to do more cases. But the literature is pointing in the opposite direction. The literature is actually showing that the two implants, single individual implants, like stud style connection, like a locator, patients prefer. And when you really look at what that impact has versus the cost of doing that versus a bar overdenture is stunning. So for me, just to do the bar, you're probably adding an additional $2,000. Easy. But when you think about a locator, you can buy the locator. It's $129, $170, somewhere in that range, depending upon your implant company. Times 2, you're saving big bucks. And then on top of it, as you were saying before, there's this one big thing that's coming in implant dentistry that people just go, they look at something and say, ooh, that just looks too complex. Zest has really nailed the locator because it's so simple and it's so easy to maintain. How many of us have done a reline with a bar? Oh, you can see it. I sometimes in my courses ask the question, how many of you want to do a reline for a 4-implant bar overdenture right now? And the sweat starts dripping down the brow.
I've actually had a nightmare about it before. I mean, a real nightmare of it locking on.
True. And it's true. I mean, you look at doing a reline for a 2 or even 4-implant overdenture on a locator, you go, no sweat, I'll be done in 15 minutes. It's just so simple. And then to change out the little inserts, you're done in about 30 seconds. And then what's really great about it is you have 6 different types of retention mechanisms for the locator, 3 for the standard range, and then 3 for the extended range. You can mix and match, and that's powerful.
And here's what's hilarious about it is I can't tell you how many times you'll go watch a football game with some buddy dentist and they'll say, oh my God, I did a reline on this lady. I mean, she's been back 7 times. And I'm sitting there thinking, you're mad at the lady. She gave you money. You did a solution. She's been back 7 times. Maybe it's you, doc. Maybe you shouldn't have done a reline. Maybe you should have placed some narrow diameter implants. Mm-hmm. So who's really to blame here?
And without a doubt, clearly across the board, more implants are usually better for patients. So if I have an opportunity to place 4, narrow diameter implants in the anterior mandible or 6 in the maxilla, holy cow, what a wonderful solution. I do tend to lean in the direction of 4 implants in the mandible as opposed to just 2 for an overdenture. But if I have a patient that's just really more medically complex, maybe doesn't have the bone, you're starting to get nervous as you get close to the mental foramen, clearly 2 implants is fantastic. It's a wonderful, proven treatment modality. But you bring up an interesting point, Howard. A part of some of the courses that we've done, or a lot of the courses, is we have a hands-on exercise for doing the locator pickup. And a lot of us will look at that and they'll go, piece of cake. Come on, I don't want to do this exercise. Just show me the surgery. That's what I came here to do. But I got to tell you, Howard, how many clinicians inadvertently make silly little mistakes when picking up attachments for a locator? And I maintain that the vast majority of complications with overdenture prostheses is technique for attaching the denture to the implants. And a lot of it comes down to the simple thing. This is one thing I bring up in the courses. It's kind of funny. If we take a denture and say our denture is kind of like this, and I go, okay, well, I'm going to have, this implant's being picked up. I put my stuff in here. I seat it in the mouth. What do we normally tell our students in dental school to do? They bite down on the denture while the resin's curing. If you think about it, how many dentures have you done where you have the patient bite down and they bite down crooked? There you go, doc. Here's how you bite. All right, bite down. They're touching their anterior teeth. And it's true, the same thing with dentures. All it takes is them biting a little bit crooked in a different direction, and they're putting more pressure over here than over here. And when they do that, what happens is the denture lifts just a little bit like this. Maybe only 100 microns, 150 microns, that's all it takes. Then all of a sudden you're locking the 2 locators just a little bit. This one's a little lower, this one's a little bit higher. Then all of a sudden you take the denture out, it's connected, you pop in the blue locators and you go, this side's perfect. No, this side just pops out a little bit too easy for me. So what do we all do? Take out the denture. I've got a solution for that. You change it out, you put in the pink one. Oh, it fits a little bit better. Still not there yet. Hold on, I've got a solution. Pull it out, put the clear one in that side, and you go, got it. All right, perfect, out the door. And then all of a sudden they come back with wear on this side. So a lot of it is technique. So what I do is I have the material injected into the denture, and then you just lightly hold it. So that way you're ensuring that the denture is seating down completely on the tissue. We're making an implant-retained denture, not an implant-supported denture. When you have an implant-supported denture, you're putting wear on the components. And as dentists, we know that whatever we put in the mouth, the patient's going to figure out a way to screw it up somehow. That's part of life. So you try to engineer it in a way like with the Locator abutment and the Locator denture components. The engineering for wear is on the non-retentive part. So how the Locator pivots, that little pink or blue clip that goes on top of the Locator is firmly anchored to the Locator, and the cap pivots over the top.
And do you, when someone's implanting this, do you like an all-new denture, or do you retrofit these under 10-year-old existing dentures?
Both. If I have an acceptable complete denture and I have a patient that has an acceptable complete denture, I'll say, listen, I could make you a new denture. I'd be happy to do that. You know how much I love making dentures. That's the reason why you're here. But to tell you the truth, you've got a pretty good denture. I can just convert this over. We'll do a reline and be done with it. And they look at you like you're their hero. And you tell them, no problem. Maybe in a couple years we'll make you a new denture once you're wearing out this one a little bit more. Because I'm going to tell you, once I put those implants in there, once I connect it to your denture, you're going to be enjoying that thing more and wearing it more. Don't worry. They'll come back in later.
Yeah, and you are their hero. You are their hero. And the dentist doing a reline where she's back on your door 5 times in the next 12 months. I mean, you're not being their hero. You're not stepping up to the plate. I mean, this isn't technology that came out yesterday. I mean, you should be on this. I'm thinking someone also might be asking, Dr. Scherer, why do you like a 2-piece zest anchor as opposed to just a 1-piece Shacken or 3M's MTech? Why do you like the 2-piece better?
I like the 2-piece because let's be frank here. I just mentioned that we're going to have some wear in the mouth. There's going to be some problems later on. Nothing against any of the other implant systems. They're all very good implants. But what I really like about a 2-piece implant is that in the mouth, something's going to break down. You're either going to get wear, you're going to get some sort of damage, an implant can break, or the abutment can break, who knows. If I can change the top part out of the implant and put a new piece on, say something happens later on down the road, perfect. And what's nice also about the Zest implant is you have a few different cuff heights when it comes to changing the tissue height of the narrow diameter implant. So if your tissue swells back all the way down and it's very thin, your implant's too tall, you can change it out to a smaller height. And that's something you can't do with a 1-piece dental implant.
I want to ask you another question. When we were talking about the rise of Edentulism, I don't know if it's different here because I'm in Arizona. I'm 100 miles from the border, but the United States gets 1 million immigrants a year. And when they come across the southern border, that's the sticking point from countries all around the world. But I'm seeing a lot of Edentulism from immigrants. I think the last denture I did, they actually were from Bulgaria and went to Central America. Anyway, made it up. And then also meth. So my questions to you are, is placing in Bakersfield, I have read, is pretty much the meth capital of America. I hear there's more. My dentist friends who are my age, even the ones that I graduated with, said that when they went to Bakersfield in 87, they hardly ever did a denture. Now they're doing dentures all the time because meth is it's crazy explosion. Out here in Phoenix, Arizona, we got a suburb called Apache Junction, and my police officer patients say that every single trailer park in Apache Junction has a meth lab in there somewhere. You just a matter of how much time you want to spend finding it. So if someone has lost all their teeth, so here's my question: if someone lost all their teeth from meth and they're still using meth, is that going to be how does implants work with someone who lost all their teeth from meth? Because meth users usually don't stop.
That's the hardest thing, too. When it comes down to it, number one, we're still doing surgery. We're still changing that person's life. If you have an active drug user that's a patient, I certainly would not treat them surgically. I don't think that's wise. I do have some patients that do come in because of amphetamine abuses and different types of medicines. It's not just meth, it's a whole host of different medicines and paraphernalia and drug uses. Clearly, the mouth breaks down. The good news is that the bone is still the bone. Once you take all the teeth out, and implants go in, there is no literature that I can think of that will show that implants have a higher degree of failure in patients that have a history of amphetamine abuse. That research might be out there. I'm just not aware of it. What I do know is that those patients many times have extensive dental needs, dental decay, root fracture, infections that can benefit from a complete denture. And those are the patients that once they get their act together can have a substantial life improvement. And many of the times they are younger as well. So we have to start thinking about treatment planning our patients for today and tomorrow. So if we place our implants, say in the canine position like we're taught in dental school, and it's a 22-year-old patient, you place two of them, 22, 27, you make upper lower dentures, overdenture, patients reform, they stop their drug abuse, everything's fine. Now, 20 years later, they say, I'm kind of tired of the denture. I'm now reformed. I've got a successful business. I wanted to spend a little bit more money. I want something fixed. If the implants are at the 22 and 27 position, it's very difficult to make a full arch like all-on-4 type restoration because you don't have a lot of room posterior to place implants. But if you placed implants, say, in the lateral incisor position, you have plenty of room in the posterior mandible to place additional implants for an all-on-4 or a DM type prosthesis. Or if you place implants in the posterior position, like in the first premolar, second premolar area, you can always add implants later on for a fixed. So I always advocate treating for today and also for tomorrow.
Speaking of all-on-4, one of the things you always hear in dental town, people will snidely say, yeah, but all-on-4 means none on 3. You don't have any spare tires. One implant fails, we lost that arch. What do you say to that comment?
I'd say it's completely ridiculous. I make no qualms about that. And that's a philosophy that I used to hear some in different parts of the country, different schools. And I tell those people that you really should look at the literature. There's an original treatment philosophy called the Brandemark Novum approach, where they would actually use immediately loaded all-on-3 restorations. And it was proven. It was very successful. It was all-on-3. Okay, and then also there's some very interesting data coming out of some of the Italian groups where they're doing all-on-2. They're doing 2 implants distalized in the canine position, and they're placing a full arch fixed restoration on that. Now, if we maintain a dogmatic philosophy, that's just my philosophy, that's just what it is, I'm not going to change it. I'm going to tell you that this is my approach. I found it to be successful. I stand on the literature. Steve Perel had an amazing article in Journal of Prosthetic Dentistry a couple years ago about his high success rate of all-on-4 restorations. If you lose one, the prosthetic survival is still 100%. You take out the implant, you put a new one in, and you're done.
Very good. When I think of you, and like I say, I'm a big fan of your YouTube, your posts. You're also really a technology guru. Talk about digital technology, intraoral scanning. What do you mean by open STL files? Is 3D printing? Is that is that Star Wars 7? Is that around the corner? Is it here today? Can you talk about technology for a little bit?
So I'm literally addicted to the latest technology that's coming out now. It's amazing, and the thing is that I really am just a computer nerd that just happened to become a dentist, and that's the truth. I literally no longer use PVS in my practice ever again, as long as just for complete dentures, and that's it. Everything else is the digital pathway. And the challenge that I have and that I advocate for other clinicians is to be able to do it in a way that's effective, both clinically and also cost effective. And that's my problem also sometimes when you look at some of the fancy technology like Sonora California. It's a wonderful system, nothing against it. It's just not right for me. I don't want to spend $120,000 on a system that I then have to literally change my entire practice so that way I can become a same-day crown place. I want to be able to say, instead of giving me the triple tray full of PVS, give me the wand. And I got to tell you, Howard, if I had to go back to using triple tray and PVS, I would stop practicing crown and bridge dentistry. I make no joke about that. It literally has taken my impressioning stress level to 0. Because you're an established clinician, you've been around, you know what doing crown and bridge is like. Other clinicians that are watching, you know what I'm talking about. You got that pain in the butt patient. She is just the tongue, and you're trying to prep. It's a mess. Then you pack the cord, and she's going, what are you doing to me? It's hurting. Yada, yada, yada. All of a sudden, then you get out the triple tray, you inject the stuff. The tongue is doing that again, and then you go, all right, bite. And then your heart is going, brr, brr, brr. God, please just get that margin. And then 2-3 minutes later, your assistant comes to you with the triple tray, and your heart is beating like this, brr, 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 and you go, oh, darn it. And you got to go back. Or, even worse, you look at it and you go, that's good enough. No. With digital scans, you literally go like this versus this, and you go, don't have it yet, don't have it yet, don't have it yet. Hold on, Mrs. Smith, I know it's kind of stretching. Boom, got it. You know definitively within about 45 to 50 seconds that you have your impression. And it's incredible. The accuracy, the precision, I will literally never go back. And I use, in my office, I use a 3M True Definition scanner. I love it. I don't care about powder. All the dental town people out there, I know you get excited about powder. Get over it. Powder doesn't matter to me. Yeah, in an ideal world, if I can skip the powder and still get the same accuracy, that'd be fantastic. But powder, just a light dusting, gives you higher accuracy and tighter standard deviation. If you look at the literature out there, everybody gets excited about CEREC, everybody gets excited about a Trio scanner. I tell you, those are wonderful devices, but they are accurate. But if you look at the spread of the accuracy, it's a very wide standard deviation, where if you look at something with powder, like the TrueDef scanner, the accuracy is very tight. And Howard, I can talk about it all day because I just love it, and I do some pretty bizarre things with it, including 3D printing in my office.
So so you have to use a lab then that uses at the other end of that 3M True Definition scanner?
Sort of. It's pretty easy for laboratories to get involved, and there's quite a few laboratories right now that allow the digital scans to come in. All they have to do is contact their 3M rep, or they contact whomever they work with. They just download their little margin marking software, and that's it. What's really cool about that type of scanner is it literally sends you something that looks something like we're used to working with, a simple model. And when you look at that simple model, it comes back something like the laboratory is used to working with. It's a die. They do their standard PFM technique with this model, and that's what's really great. I don't want to say that all ceramic restorations work everywhere. I'm pretty conservative when it comes to my dentistry. I still really like PFM. I play with zirconia. I like also, monolithic zirconia in the posterior mantle, but in the anterior, PFM. It's beautiful.
So explain to the dentist how the lab receives this on the other end, like on their internet, on their desktop computer. How does the lab take it from there? What do they do? Is this 3D printing?
It is. So with most of the scanners right now on the market, what they do is they get this STL file. It's uploaded to them within about 5 minutes of clicking the button on my scanner. It's already at the laboratory. Then the laboratory technician gets the file, they open it up in the software, and they go, here's the margin, they mark it, and then they slice the dies just like they would normally do, and then they issue a command, and it's sent to an industrial-grade 3D printer. It's printed on an articulator, just like this, removable dies, so if I wanted to remove the die, there it is, and then it comes back to the laboratory with a triple tray. Just like what you would see here. They're very used to working with die models that look like this. You wax up on it, you cast the coping, and then you check the occlusion. It's literally no different from their current workflow using this technology. And that's where it's an adaptive technology as opposed to disruptive. Because if I can do something, instead of saying triple tray PVS impression wand, same thing on the laboratory side, instead of saying impression triple tray PVS, digital file, 3D print. Everything else is the same. So if I still want to do my tried and true PFM crowns, I do that. If I want to do monolithic zirconia, I do that. If I want to do lithium disilicate like Emax, I do that.
And some of these labs are saying, since I don't have to pay a person to pour up the model, trim the die, do all that stuff, some of the labs are actually giving you a discount if you use it. Have you seen that?
I have. And that's...
And have you seen that? And what labs are you using?
So I use a variety of different dental laboratories. I really like Precision Dental Arts in Idaho. They're a wonderful digital lab. Also, I use Advantage Dental Laboratory in Tallahassee, Florida. They're incredible for aesthetics. And then I also use California Dental Arts here in Northern California. And all three of those labs are incredible. I've used Arrowhead before. They're an incredible laboratory as well. And I know a lot of clinicians really love Glidewell. It's a fantastic lab. They are super digital as well.
If you have any buddies at any of those labs that want to do a podcast about the other end, I mean, you're the dentist, prosthodontist sending it. If one of your buddies wants to do an hour about receiving it and all that, I would love to do a podcast on that.
I'll certainly pass it along.
Some labs are saying, do you believe this or not? Some labs are saying that when they get a PVS and they have a human pour it up, trim the die, whatever, they're averaging 6% remakes. But when they have optical scanning like you're talking about, it reduces it to 1% remakes. Do you believe that?
1,000%, 100, 120, 1,000%, whatever you want to call it, without a doubt. And I can clearly attest to that too, because I've had a couple of situations where, you know, the laboratory technician maybe, even on the digital side, you still have a human component. And the technician said, oh, I think that's your margin right there. It comes back, and I look at that and I say, I tried in the mouth. Nope, they missed the margin. So in our traditional crown and bridge world, if you miss the margin, they've already poured the die. Your first pour is the most accurate. If you have to remake the crown, you got to pack cord again and make a new impression. But with the digital world, I say, I'm sorry, your crown, well, I just got to go back to the laboratory. There's just a couple things that need to be changed. No problem. I'll see you back in 2 weeks. I call up the laboratory and say, remember that file I sent you? Go ahead and remark the margins. You just missed this little distolingual edge. Send it for 3D printing. It's the same file. It's perfect. So then they make one minor change and it's corrected, as opposed to having to redo the entire impression. That's incredible.
In economics, I have an MBA from Arizona State University. In economics, we say price is 4 out of 5 answers. On the 3M true definition, how much does a system cost, and is there a cost each time you take the impression?
No, there's no per-click fee. The scanner itself is approximately $15,000. $15,000. And it's the lowest priced of all the scanners on the market right now. And that's a big reason why I kind of was leaning in that direction. But forget price. When it comes down to it, I still need something that's accurate. So it is the most accurate scanner on the market, just happens to be the cheapest as well. And I looked at some of the other expensive scanners. You can get a scanner anywhere from $25,000 to $55,000 for a scanner. And when I look at that, Howard, I say, well, most clinicians could afford that, no problem, if it was that much better. But in all reality, I would love to be able to say, I can get out $40,000 cheaper and still have the same quality in my practice, and that's what I've done. Every system pretty much has a yearly fee where you have to keep their software up to date and then also pay for a certain amount of applications. And when it comes down to it, you can't get away from it. It's usually a couple $100 a month, somewhere in that range. Some are higher than others. And with most scanners, there's only 1 or 2 on the market that have a per-click fee. The scanner I use does not have a per-click fee. I would not use a scanner that has a per-click fee because it creates disincentive for me to experiment a little bit in my office. And I'm a computer nerd. I experiment a lot. So, I just scan just for fun. And then I 3D print in my office and, use some bizarre things. Like here's a 3D printed denture that I just 3D printed.
And are you printing anything for clinical purposes or just hobby purposes?
Well, it's tough right now because currently the in-office 3D printers that are rated for using for real purposes are incredibly expensive. So if you...
How expensive?
Usually about, at the low end, about $16,000 to $18,000. On the high end, $85,000. somewhere in that range. And if you're a dental laboratory that depends on 3D printing for your crowns, your dies, your margins, spending that money is worth it. Say you have a production lab, you want to generate surgical guides. To spend $20,000, that's just what you have to do. But for me, what I use it for is kind of playing around a little bit, but also with some seriousness. So something as simple as, like this patient, she had mobile anterior teeth. If I made an alginate impression, I would have extracted the teeth. So I scanned her, 3D printed her teeth, and then it allows me to do a simple vacuum form matrix on the top. So that way the next time I see her, I have something to make a temporary with. So I extracted the 4 incisors, prepped 22 and 27, and now I had a vacuum form matrix for temporary based upon my own 3D print. And in my own office, that 3D print cost all of maybe $5, where if I send it to a laboratory, a model like that sometimes costs $25 to $35, somewhere in that range.
I don't want to get you in trouble because you're not supposed to speak for your spouse, but you did say at the beginning of the program your wife is an orthodontist. Is she orally scanning for indirect, like Invisalign or ClearCorrect, or is she doing this too? Do you guys share an office, or do you have 2 separate offices with separate equipment?
She has her own office. She works at an orthodontic practice here in Sonora, and then she also does some, per diem type work at some different offices around California, just helping out locum tenens type dentistry. She does scan quite a bit for Invisalign, and to tell you the truth, it's very effective for her, but also it's pretty quick and pretty easy to make an alginate impression. So speed and efficiency wise, it still is a little quicker to use an alginate for a retainer, for the upper or for the lower. But when it comes to what I do on the crown and bridge side or the implant side, it's much faster to use scanning. So there's still some limitations there for scanning, but you can get a whole arch scan in about 60 seconds.
And what would you say? I got to wrap this up for you. I'm just honored you gave me an hour of your time. You're so amazing. What would you say a big amount of the people consuming my podcast are young dentists, senior dental school, just got out. What would you say to a kid who was sitting on the fence of whether to go into general dentistry or go do a prosthodontic residency, like you're a prosthodontist? What do you say about that decision?
Well, the challenge is in today's day and age to consider the costs of dental education. And it's very difficult right now, the thought of spending an additional 3 years in residency after 4 years of dental school when you have over $400,000 in student loan debt. That's a challenge, especially if you have a family. Many times you do have to start working right away to start paying for your family and your expenses. My direction in life was to try to be the absolute best that I could be, the scientist that I could be, and I just really personally felt prosthodontics was my calling because it allowed me to explore the science of things. I was a general dentist for 2 years before going into prosthodontics. I love general dentistry as well, and I encourage you, if that's your passion, stick with it. My passion was in implant dentistry as well as full arch implant dentistry, overdentures and dentures. And for me, I had too many questions out there that CE could not answer. When I spent 3 years of intense learning in residency at Ohio State with my team and Dr. Campani and all my co-residents, the lateral learning and all the learning that we do with that is just worth so much in continuing education dollars. And unfortunately, there's just not the world's best education out there for things that I want to do on a regular basis, like complete dentures. And I just felt the calling to go back to prosthodontics, but also it allows me to become an educator, to be at the universities, to do bizarre things like this in my life where I can 3D print somebody's mandible in my own office. It's incredible. And I know we can all do that as general clinicians, and there's quite a few out there on Dental Town that are doing some very inspiring things. But I have a passion for prosthodontics, and I wouldn't change it for the world.
And if one of these listeners wanted to get a hold of you, are they able to communicate with you in any way?
Absolutely. You can certainly send me an email address. I give that out. It's mds@scherer.net. So my 3 initials, Mary David Smith @Scherer.net. Or you can always just find me on LinkedIn. I have a profile on LinkedIn, Michael Scherer, or you can always call me at my office phone number, 209-536-1954. I encourage it.
And any chance our listeners might ever get credit for taking an online CE course from you on Dentaltown?
Absolutely. If I had the invitation, I would be happy to do one for you.
Oh, it would be the hugest honor. I think you are so damn cool and so smart and so amazing, and I think it would just be amazing. I mean, and plus you've already got all the material on your YouTube channels. Most of that would be a matter of just repackaging existing stuff that you've already done.
And, one thing we can always do is be able to have incentive for CE. Now, I still do believe in having open channels and easy accessibility for anybody, and the YouTube channel is a big passion of mine. But if there's anything I can do for Dentaltown to help you out, it's such a wonderful resource. What you do, Howard, and what you've done with Dentaltown, it's so admirable, and I thank you for being able to contribute to clinicians around the world and to be able to educate. The indirect vision of what you've done with Dentaltown is so incredible.
It's incredible only because of guys like you who are sharing. And that was from Dr. Scherer. Thank you so much for an hour of your time. You just rocked my world, and I bet all our listeners are going to probably play this one over 2 or 3 times.
Well, Howard, it's a pleasure. Thank you for your time, and thank you for everybody's time for tuning in out here. It's a pleasure.
And we look anything you want to do with the online CE, we just would love it. And like I say, dentists need to stop complaining about the Realignment lady coming back 5 times and start stepping up your game so that grandma never has to come back and you can increase her quality of life and be the hero that you should be.
I tell you, you do good dentistry, you look at a patient straight in the face with confidence and conviction and say that something is going to change their life, believe in it. Implant overdentures will change their lives. And the patients will be walking out money on the table in your practice as opposed to walking down the street.
You'll make money, and think of all the money she'll save by not having to do a $50,000 all-on-4, which 9 out of 10 are never going to buy anyway. I mean, you're not losing any money if grandma can't afford it. But if grandma can't afford a $50,000 all-on-4 and you're not offering a $5,000 solution, I mean, come on, step up your game.
And in my practice, I have literally gone crazy with overdentures and so many happy patients. It's incredible. And to tell you the truth, some of them will turn into all-on-4s. You'll have that opportunity, but treat your patients like you would want to be treated, and you will always have success.
And we will end on those words. Thank you so much for your time, Dr. Scherer.
Howard, it's a pleasure.